Hi to everyone. Uh, Today's moderator is Dr. Rupa Salvan. I need to introduce her, and she is a great intervention cardiologist in Delhi. I'll request Dr. Rupa Salvan to start the proceedings, please.
So, good evening, everybody, and welcome. It's such a privilege to be a part of WINCARS, and the way we are growing shoulder to shoulder, I think, it makes me feel very happy that we are such a important group today. So, without much ado, let's start the session. And, ma'am, who would be the first presenter for today, Dr.
Suma.
Suma? So, Dr. Suma, I would invite you to present your case. You're presenting a bifurcation and an ACS, I understand.
Yeah, that's right.
So, welcome, and it's all yours.
Thank you, Dr. Rupa. At the outset, thank you, Dr. Jyotsna, for inviting me. So today I just wanted to show, instead of a complex case, I wanted to show something that we encounter in our everyday life and how to deal with those kind of things, especially with regard to bifurcation lesions and acute coronary syndromes. So this is a 61-year-old gentleman. He is an hypertensive. He had an anterior wall MI, was lysed with streptokinase outside. Then he was referred to us within a couple of hours. He was in cardiogenic shock. He had recurrent ventricular tachycardia. He was DC watered in our ER, and cardiac arrest was resuscitated. His echo showed moderate LV dysfunction, and he was taken up for an angiogram immediately. So we did not intubate the patient because after we DC watered him, he was conscious, and we had started him on good inotropes. Pressures at this point were reasonably good. And also in the ER, we've given some heparin, so that might have helped with the flow. And this is the coronary angiogram. You can see there is a tight osteal LAD lesion. So this is the angiogram. The right seems to be okay. So I would just like to put forward a question to the panelists as to what would be the strategy in this patient, given this is an acute coronary syndrome, anterior wall MI, thrombolized, and this is the lesion. So what would be the strategy?
I would think that first
Yeah.
going to the smaller nitty-gritties, that this patient received thrombolysis. So what was the ischemic time, and the arrhythmia happened as a reperfusion arrhythmia after streptokinase, and what was the resolution? Because
No, he was in cardiogenic shock. He was a VT, not reperfusion apnea. He had to be shocked.
I correct. So now I would go to the extent that before calling shock, see, SCI has given a very clear definition of A, B, C, D, and E. So when we talk of shock, we talk of an APG, the lactate level, the acidosis, the amount of inotrope that's going. Because a patient who is impending shock, or there are many issues that happen in shock, and the lactate and deciding what you do, the extent of pulmonary edema, urine output. So there are many factors that the outcome of a patient would depend on how deep he is in shock when they come into us. So that would be very important. And I think going ahead, every STEMI, we all must take the time to document all these things, because it affects the strategy. So if your lactates are high and the patient is in pulmonary edema, tubing is important. If it is BF and you've shocked and the pressures are on a low amount of noradrenaline, yes, you can go ahead and treat. And if the inotrope requirement is strong, it is very, very, very important.
No, actually, I was thinking, like, what would be the stent strategy? Like,
unload. No, sorry. So, we are in an MI. I'm very clear that we have to unload the ventricle. It's the patient. The angioplasty or bifurcation strategy is fine. But when we talk of a STEMI, it's the patient, and unloading the ventricle before handling the lesion is very important if we believe it's cardiogenic shock. So of the supports that we have, giving a balloon pump, I think, would be important if the patient is in shock. And if it is impending shock and the patient is stable, then we would just go for a bifurcation. I mean, in a STEMI, it would keep it simple, keep it one stent, and protect the side branch, and do a provisional stenting strategy when it's a STEMI.
Okay, Dr. Jyotsna, your comments?
Yeah. Even I wanted to stress that whenever the patient is recovered from the cardiogenic shock, even though it's transient, I think there's some support, especially of the nowadays IABP is approved to be not to have them much of an impact. But in Impella, the other the left ventricular assist devices, if the first has to be assessed, even though the pressure has come down to the came as a normal now. It otherwise at least it has to be kept as a standby. And as you already see, this predominantly is an osteal left main, but most of the time, as the last time also we discussed, most of the time it is extends into the left main, the osteal LAD. So I will go with the strategy of the provisional stenting, but definitely after the provisional stenting, probably I will take the NIVERS. I may not start with the NIVERS or the imaging. In the acute MI conditions, without wasting time, we should have the opening up of the pressure. So my first strategy is a stabilization with the left ventricular support, and then a second step is the provision stenting.
So
Okay,
I
great.
kind of
So,
comment that we look down a lot on the balloon pump after the trials that have come out, but all of us have saved so many patients, and it is time to really put our data. I'm not intimidated by the impeller use, and that's the only life-saving thing. I think what we have also works very well, and we just need to make our own data.
okay, so we don't have Impella yet. So this was my strategy. First, whether it is should be the patient was hemodynamically stable at that time. So I've seen the patient on the table, pressures are okay, noradrenaline is going on, some little bit of dopamine fluids, and so I've seen the angiogram and I've decided whether one stent strategy versus two stent upfront two stent strategy. So here the lesion was 0 1 0. Side branch ostium, that is sarcostium, is free of disease, and there is easy accessibility of the side branch. I didn't think that accessing a side branch in case of any eventuality is a problem. So these three factors would push me towards a provisional stent strategy. Suppose if there was it is a Medina 011 or severe side branch ostium, or side branch ostium is very difficult to access, or these are some of the factors that you would consider before you decide this strategy. Then, having decided one stent strategy, you have to think of whether you would put the stent on the LAD ostium versus crossover from left main to LAD. So in this case, I've decided to do a crossover because distal left main is clearly was diseased, and the angle between the LAD LCX was narrow. It was not a wide angle. And although there is a good visualization of LCX takeoff, which would in fact favor an LAD ostial stent, because there is a short left main also, I decided to go for a crossover left main to LAD. Coming to the imaging, acute pulmonary syndromes, OCT may not be the most ideal because you might have disturbances with the flow. So plus I'm planning for a left main to LAD stent. So I've decided to go with an IVUS and told them to open the IVUS. Apart from that, we've also decided to wire the LCX, keep the IBP standby with a extra sheath in the left groin. And we've started on GP2B3A inhibitors, and we've got all the medicine kit ready for the slow flow.
So I would just like to interrupt at this point that dopamine is not the inotrope of choice. You said dopamine, we should be on noradrenaline.
Yeah, I mean, he was on noradrenaline, but that the pressures was low, so somebody started dopamine in the ER. So ideally, we would not stop. Dopamine is not the drug of choice. I agree with you.
Second,
So,
if you've used streptokinase, why are we not going radial? And and how long ago was streptokinase?
No, streptokinase is given, but we've always we do a Doppler puncture of the femoral artery, and in this case, a patient was sick in cardiogenic shock. So, just to be on the safer side, our guys have taken a femoral access, and I agree with it. We are more comfortable doing a femoral access in a sick patient than a radial. We think it saves the time as well.
Yeah, to add to this point, what I think is not just because we gave the streptokinase, but otherwise also in a sicker patients if they require an IABP, so that you can save at least one groin. So you use the one groin and one radial, still that is a good strategy. If you have a complications immediately, you can put an IABP or the left ventricular unloading devices, and you can go to the radial. So that is a good acceptance of the
I
radial
mean,
angioplasties nowadays is coming up very much.
I think
sure,
it's
sure. I know there are some registries which have shown that radial access is better, especially in rescue PCIs. I agree with
One
you.
more point I want to say is about the plaque distribution. In the angiocardiography also, if the plaque distribution is more towards to the upper surface of the LAD versus the lower surface of the LAD, the plaque shifted to the circumflex. Like in this is a very significant lesion which is present both in the upper and the lower surface of the LAD. So this is likely to have the plaque shift. So as you already described, the angulation of the circumflex and everything is in favor. So even though the clock shift occurs, we need not to worry much about it. Still should be a provisional stenting should be our strategy.
Yeah, agree with you. So we wired the circ, then we wired just measured the length. What would happen? I mean, what would be the length in these patients? Then we went ahead, took a 6 French GBU. This wired with one BMW and cyan blue into LAD. And we've taken a short 212 balloon into the left LAD ostium and just dilated. And to my surprise, it was a very fibrotic lesion. You can see the balloon was not dilating at all. So once we knew that it was a fibrotic lesion, not very soft lesion, I went up to about 12 to 40 atmospheres with the balloon. Now, what happened immediately after I ballooned, patient crashed. There was no flow. I mean, we didn't save that one shot, which was done under fluoro, but there was no flow in LAD and as well as circ. So at this point, what in my mind, the thinking was that since it's a fibrotic lesion and we have ballooned and went up to 14 atmosphere, could it have dissected somewhere in the near the bifurcation? So immediately we tracked down a 3.5 into 33 science expedition. We already got it ready because we measured the length and deployed at a nominal pressure. So once we put in the stent, so this was the result. The circ flow has come back, but the LAD, there was no flow at all. So, so at this point, the thinking was, if it's a dissection, if we put a stent, at least some flow should have come into the LAD. If it didn't come, then obviously it's no reflow. While we were doing this, my assistant was putting in an IVP, so patient was stabilized a little bit. We've given some increased the inotropes and the other things, and what to do next.
No, one more point is whenever you don't have the flows like this, you should use a microcatheter with another wire and try to inject the distally so that you will know that where is the problem than using an imaging at this stage. Because imaging is going to be detrimental and more of the contrast and more unstable patient.
No, we
So
were not
definitely I
thinking
will
of
take a,
imaging at all.
yeah.
We were
So
not thinking of
I will take,
imaging at all.
sure,
We
good.
just stented the stent. I have
Yeah,
stented
even
nothing into
after the,
LAD and
even after
not
the,
thinking of imaging at all.
yeah.
So we've
So
given
now,
some termin, we've given intracoronary epinephrine, intracoronary SNP, about 200, 250 micrograms we have given, and now the LAD flow comes back.
yeah, that's what I mean to say, that everything should be given through a microcatheter distally, then it is going to be more effective. And the second important thing is you can demonstrate where is the problem. So if you have another wire and a microcatheter, so you can give them all the materials, whatever, all the drugs, whatever you want to go, pharmacotherapy
Yeah.
you want to give, you can give. And second one is you can withdraw it and you can demonstrate where is the real pathology, and still you are protecting with an other wire. So that is the best strategy when we don't have the no reflow than intracoronary,
Yeah,
exactly into
correct.
the distal bed.
Yeah. So what we usually do is we push in some termin immediately to make sure the pressures come up. Once the pressures come up, the flows automatically, they become better. And then we give some intracoronary epinephrine and all that stuff. Once the pressures come up, we keep giving SNP slowly. And here my guide is well approximated. I know I could have taken a wire and taken a microcatheter, but thought, okay, let's give some 100 micrograms and see with 100 micrograms we got good flow. Then gave another 100, 150, and we got good flows. So we didn't require a microcatheter here. So next, we had done a pot using a 4.5 into 10 balloon into the left main. So just this I've taken from the European Bifurcation Club as to how to do the pot. Pot balloon should be sized 1:1 to the main vessel. And you can see the center, I put it in a red circle. The pot balloon should exactly land just proximal to the carina. That is exactly the right place. What happens if you go down into this main vessel? If you cross the bifurcation point, you're actually pushing the carina into the side branch, and also there is a risk of perforating the distal vessel. And if you don't cover it properly, then you're actually not deforming the stent, to suit you to wire the side branch. You're still going to leave a lot of struts at the bifurcation point that are not going to be ideal. So the exact pot balloon should rest just proximal to the carina. So this was the result of my pot. You can see, ideally, when the main vessel, the pot, the stent proximal to the bifurcation should open up into the side branch. So I got a recent decent result here. So went ahead and rewired the circumflex, and I've taken a small 215 balloon mini trick and dilated since the ostium was pinched significantly. So once I dilated the side branch, this again very important while you're crossing, to cross in the distal strand. So if you can see the wire which is crossed here, the proximally, what happens, whether you do a side, just a side alone, or whether you do a kissing, you leave a metal carina, which when you do repot will fall back into the side branch and will occlude it. Then you will have a big problems if you want to rewire it or do anything else. So very important to cross through the distal strand here. So I've crossed and I've done the side dilatation with the 2 balloon, and so this was my result. The sarcostium seemed a little hazy, so LED looks good. So we went ahead and we did a IVUS. Okay, so this is from LED. Stent landed good. There was no dissection. Seemed to be well opposed. And the areas at all points seem to be quite adequate. So that was the IVUS from the LED. Now coming from the circ, there seems to be some distal disease, and that was the ostium. And but the area was good. There seems to be some plaque shift into the sarcostium. Now, what do you think we should do at this point, Dr. Jyotsna?
Yeah, still we should do the FFR. In acute MI nowadays is well considered the FFR because you have the distal disease, and the ostium or the circumflex looks to be the okay. Even though now the ostium is not going to be a major problem for you for a provisional stenting, but the distal disease which is looking to be quite significantly obstructing the lumen. So definitely I will do the FFR for this case.
Even for an area about the smallest area at the LCX ostium I got was 5.24 millimeters square. Would you still do it?
Yeah, I'm not bothered about ostium. That's what I said. Ostium looks to be the okay, but a distal to the ostium, there is a significant disease which we are not able to pick it up by the angiography. For
Distal
that,
to
of
the
course, FFR is not an ideal nowadays. RFR is an
distal,
ideal,
distal is
especially
6.11. Where you saw the disease, the lumen was 6.11.
really. But I thought it is quite significant. If it is 6.1, doesn't require anything.
Yeah. So, so very often what we see is when in the crossover stentings, after doing a pot, after you do a site, and this is how the ostium will look before and after. The Because of all the intervention that you do of stenting into the bifurcation area and the pot, what happens was the ostium, as you rightly said, becomes deformed into an eccentric shape. This eccentric shape itself is not a reason for concern. If the area is good enough, then it doesn't require anything else. You don't have to think it is pinched just because the ostium is elongated or deformed. So in our case, the areas were good. Ostium seems to be okay. So we decided to leave it at that. So this was our final result. So the this is from the EBC 2020, which has recently come out, I think last week. The sequential application of single balloon dilatation in the proximal main vessel side branch and then report is appealing due to its simplicity, efficacy in bench tests. So recent data documented that this technique is probably even less simpler than theorized, even much simpler than that pot kiss a pot report. In particular, sideband ballooning induces a distortion of the main vessel stent, deserving appropriate correction, and is only possible to clear sideband stent struts when performed after distal rewiring, similar to kissing. Thank you. That's the end of my presentation.
Yeah, it's very nice presentation. It's very good and illustrative. Finally, the good result. That is the most important. Just I wanted to add that FFR is not required nowadays. RFR is much better. Even in acute MI, now the study is started on an acute MI. So that decreases our strain.
Yeah, I
Dr.
would say
Rupa?
a good illustration of the problems we see while doing a STEMI intervention. They were slow flow after pre-dilatation. I would be very hesitant to even worry about chasing that circ. I mean, the result was very good. You've shown very nicely how you do a pot. And I would just go back to emphasizing you must know the streptokinase, heparin, and of course, access is whatever your lab you're comfortable, radial or groin. I mean, whichever what is the normal practice in the lab, please do that. And I would be very hesitant to use SNP. I find adenosine and adrenaline extremely good in a hemodynamically unstable patient. And as Madam said, go down with a perfusion catheter. It doesn't take time. It's these are again lab cultures and lab habits where everyone is tuned. SNP I would worry about. We've talked about dopa, noradrenaline. We've talked about unloading of the ventricle, and
Somehow
I
we've
would
always given SNP in Cisco and it's
I
worked
would
for us.
support ask
We're very
everybody to
used to
go on
giving SNP and intracoronary adrenaline in our labs.
adenosine and adrenaline work extremely well in a hemodynamically
Yeah.
unstable. So I would encourage everybody. I think, madam, we must have a dedicated session of shock A, B, C, D, and E. And patients, and be very comfortable seeing how much their lactates are. What is the CO2? What to because the patient will go down 2 hours, 3 hours. You come out of the lab and you are also on your end. You leave it to the CCU without a proper direction of where the patient's going. That's when most of the problems happen. And once we start planning and telling them ahead, our ICU cares will also get better on tapering inotropes, keeping the lactates right, maintaining the output. And we should all be, I think, more comfortable discussing the entire management beyond the cath lab also. In subsequent sessions, it will be great if we spend more time on this because I think everybody is self-trained and everybody is hesitant to commit on what you do. I'm very comfortable, taking up these discussions and helping our peers to manage shock better.
Yeah,
Okay,
just
thank you all.
one.
I think I should rush to cath lab. Thank
Yeah. Yeah, only one thing I wanted to add it is actually I whenever the patient is in a cardiogenic shock, I give the inotropes for the systemic pressure management. But for the with the microcatheter, I give a vasodilators into the coronary bed. Nothing will happen. They will recover very very well. So maintain with the systemic pressures and vasodilatation of the coronary vessel. Yeah, I think we can running short of time. Can Madam Rupa? Can we go for the
Yes.
other case?
So, would be the next presentation on longitudinal
No,
by
no,
Dr.
no. Sujata's is the going to be the longest one. So we will request
Okay,
Sujata.
to request Dr. Sujata to show her angioplasty. All over to you, Dr. Sujata.
Oh, sure. I'm sorry, I
Sujata is not only the best friend of us, but she is the first idea to get these interventional rounds, and she encourages really all the people. And her plan is to like a in the US they have done all the females doctors are doing the intervention. She also wants the similar way to do it here. We hope we do it. Please, Sujata.
so this basically I'm trying to encourage all to do live cases, do it. So basically, it's a simple case, and I would like to make us better in doing the live cases and encourage us to discuss more the issues involved. So I'll be presenting the case and pausing at appropriate locations so that we can go ahead. We are doing a case, and I have with me my team, Dr. Anil Mahapatro, my nurse, Rama, and my technician, Ramakrishna. So I have a 63-year-old lady who presented with recent onset heart failure. That is, she presented with dyspnea, no history of angina. The ECG was unremarkable. The biomarkers showed elevation of BNP. The troponin I was normal. The high sensitivity troponin was normal. So, in view of recent onset heart failure, she was started on diuretics, beta blockers, ACE inhibitors, and statin, and she was taken up for coronary angiography. So, at this point, I would like Ganesh to share the echocardiogram. Ganesh, share the echocardiogram before we go on to a discussion of the. So, already Dr. Chandramukhi is also with us. So, basically, this is a young heart failure patient. So, basically, first thing we do is an echocardiogram, and okay, present it, Ganesh.
Dr. Ganesh, you are on mute. Can you unmute yourself, please?
Okay. Hi. All right. You can hear me now?
Yeah, we can hear you.
Yeah. Good evening, everyone. Yes. This is M mode EF which I measured first going to the before going to the strain imaging. I could get a 42% of EF, but by seeing the cut also there is some desynchrony I can feel. I couldn't demarcate my uh, edges. Then I did an strain. This is 4-chamber view. You can see each and every segment has been given colors, and you can see the synchrony waveform, and you can see the aortic valve closure time, which was not every segment were not approximated at the points. Looks like it is an desynchrony, and I got it is 4-chamber view. I got a 38% of EF. This is apical two-chamber view, where you can see there is a bit of desynchrony here also, and there is a strain of minus 8.4 over here, and EF biplane EF it is 16.5. As apical three-chamber view, you can see the same thing. There is desynchrony, and the strain is way low. Why? Because the interval is more involved over here. You can see the interval here. So it is minus 6.3% over here, and this is the bullseye. You can see by LV biplane EF it is 27.5 in global longitudinal strain, whereas in M mode it was 42, which was misleading. And here we got LV global longitudinal strain of minus 7.8%. Madam, you can continue.
Dr. Chandramukhi, comment on the.
Is it Dr. Chandra?
Hello.
Madam, please comment.
Yes. Good evening, everyone. Thank you, Joseph, madam, for meet. So, like in this case, we have done the global longitudinal strain. So, global longitudinal strain is a measure of the LV systolic function, and it is a better marker of LV function even than LV ejection fraction, which has already been seen in this case. And if we take the global longitudinal strain, it is the overall assessment of the LV function. If we want to assess the regional ejection fraction or regional contractility of the segments, then we can assess with the regional strain, which is indicated by the various curves. And the peak systolic strain, which is indicated by the various curves, the timing of these curves will indicate whether there is any dysynchrony. So in this case, we saw that there was scattering of the peak systolic strain in this case. So there was a little bit of dysynchrony. And if we measure the time intervals, then we can identify whether the delay is significant or the delay is not significant. So overall, in this case, the global longitudinal strain is very low. It is less than 10%. So definitely there should be some scarring of the myocardium. And if we see any 2D images, then we will be able to know like where is the regional wall motion abnormality and which areas are affected, and we can correlate with the global regional
Anterior
strain.
wall. It was in the anterior wall. RWMA was there in the anterior wall.
Yeah, and in the three-chamber view, you showed that some of the segments, they were out of phase. So, and in the bullseye also, we could see that there were some blue segments at the apical level. So these segments were out of phase and they were kinetic. So these things we can make out very clearly if we do strain
so can
imaging.
you enlighten us on the scar versus this thing? Because echo-wise it is looking like a quite thickness is well preserved. So we don't consider the scar. So can you enlighten us the scar versus the ischemia?
Scar versus ischemia, if the strain is less than 10%, then there is a very high possibility that the segments may be scarred. But only depending on the regional longitudinal strain, we cannot make out whether it is scarred or whether it is just a stunned myocardium. So for these cases, we need to do some viability assessment. Then only we will come to know whether there is any scar or it is a stunned myocardium. Here in this case, because the overall thickness of the myocardium is preserved and there is no any hyperechogenicity, then actually we would like to correlate to make out whether there is any scar. We have to correlate this case with MRI.
Okay, thank you, madam. Please, Sujata.
Thank you, ma'am. I'll go ahead with the presentation. So what my angiogram was showing.
The angiography revealed a critical lesion of the LAD in the mid-region and unremarkable circumflex and the right coronary artery. So at this point of time, we decided to do an angioplasty of the left anterior descending using physiology guided approach. So basically, before doing the angioplasty, we just wanted to know whether this LED was viable, territory was viable or not. So on an experimental basis, we put the FFR wire across the lesion into the distal LED, and our premise is that if the myocardium is viable, you'll get a positive FFR, and if it is dead tissue, the FFR will be negative or more than 0.80. As you have seen, the LED is showing an aneurysmal segment properly, followed by a very critical LED lesion. So we just recorded the FFR. We wanted to record the FFR on an experimental basis only, with nothing in mind. So as we cross the lesion, you can see the baseline FFR itself is 0.28. And as we pull back, you can see that in the proximal segment, it is normal. So it's a significant lesion, and according to us, there is viable myocardium downstream. So this patient will benefit from an angioplasty.
Sujata, I wanted to add some point here. This is not an experimental. It is a well-known fact that in the lab we should able to demonstrate the viability in this way only. But only one problem is FFR whenever we calculate directly by using the adjusted machine is not reliable in this, because these people are going to have the LVDP is high. So the transpulmonary gradient, what is makes the difference for the ischemia. So the best thing is, because we may not able to simultaneously the see the LVDP when you are, otherwise we require a 2 arterial punctures, which is a waste. So many people prefer to do the right atrial pressure and subtract from the both the pressures before in the proximal segment as well as the distal segment after the crossing the lesion, subtract the right atrial pressure, and then manually we had to calculate the FFR. That is going to be much more reliable. Or otherwise, even though it is not so simultaneously, you can test the LVDP and you can confirm that LVDP is not much elevated, then all this exercise is not required. Why I'm saying this is you took all the trouble to demonstrate that the patient has a much more LV dysfunction than ejection fraction wise. So I think it is more relevant if you calculate the FFR in this way.
So I just want to add. So as you have said, we have to take the venous pressure into consideration. So we have to measure, as you're saying, we minus the PV, like it is PD minus PV by PA minus PV. So this becomes more relevant when it is at the borders, like 0.80. In such situations, maybe a measurement would be more useful. Would be more relevant in subtracting. But in a situation like this, a 0.22 value is something really low and it doesn't need further validation. And my premise is this is viable myocardium.
Yeah, yes, exactly. I agree for that. There is no doubt. But for the student's sake, I wanted to say that when the LV dysfunction
Yeah,
is there,
yeah.
this is the
We
method to be
have to
done.
take the PV into consideration, and I would like to assert that it is PD minus PV by PA minus PV. And so when the so you minus the same value from below and above, and so when the situations are borderline, we are worried. But when a value like this, I'm not worried. So around 0.80, I'm definitely worried. And this is, I also want to point out to the panel that this was a baseline, and I did not use any adenosine. So it was a baseline thing. Now, I just put it across the lesion to for us to get a sense of things, how things go. Dr. Rupa, do you have any comment on this?
No, I agree with what you are saying. It's very relevant and it's fine. I mean, the in a situation where so much is happening and it's clearly it's FFR is positive, so we go ahead and treat this lesion.
Ma'am, we can't hear the voice, ma'am. Ma'am, did you change the voice settings of the computer? We can't hear the voice.
Yeah, even I am not able to hear.
Dr. Sujata, ma'am, we can't hear the voice. Ma'am, you're on mute. You're on mute.
Okay. You can't hear my voice, Ravi?
Now I can hear
On
your
the
voice, but I couldn't hear the voice of the video. It got paused.
oh, so basically I'll unmute it and then I'll talk.
Please, ma'am.
Okay. You can hear me, Ravi, now?
You're audible, ma'am. We can see the
Yeah.
video.
So basically, we use the MLD max algorithm. So we looked at the morphology, we looked at the length of the lesion, and we looked at the diameters. We looked at the reference diameter distal to the lesion and the reference diameter proximal to the lesion. So we basically use the MLD max algorithm in this patient because basically why we are using OCT. Does OCT help in imaging? And I mean, do we do in simple lesions? But we had a segment which is aneurysmal, and we are trying to use a stent which is more than 28 millimeters. So based on the data nowadays, where we are using more of imaging guided interventions, as we have seen in presented in TCT 2020 recently, the data from the ultimate 3-year registry where IVAS guidance is supposed to be better in reducing the target vessel failure and clinically driven target lesion revascularization, and and where the stent lengths are more than 28 millimeters, the long term data from the IVAS XPL, and possibly we could we could extrapolate the same data to OCT as and basically this proves that imaging guided PCI is definitely reduces the target vessel revascularization. So in this patient, we decided to go ahead and do the OCT, and at our place also now we have the eye optico study which was presented by Dr. Ronnie Matthew at TCT, and that has shown that in 90% of the cases the strategy has changed. So we went ahead and did the pre-OCT, and you'll see the images which will now spring across the screen. So basically, the MLD max algorithm has made the situation. So you can see the OCT catheter as it comes across. You can see that there is a mixed plaque. And basically, I want to tell that before we placed the OCT catheter, we pre-dilated with a tube balloon just because it was a very critical lesion. You already saw that it was a near occluded LAD. So in effect, to get good images, we pre-dilated with a 2 image, and you can see a fibrofatty plaque, and you can see there is a reasonably normal segment in between, and again we come to a very critical segment, and you can see that proximally that there is a very aneurysmal segment. You can see, so basically we did the measurements. So this is our landing zone distally, and there you can see the EL to EL diameter of 3.36 and a lumen diameter of 2.7, and proximally we plan to land proximal to the aneurysm, and we found that we didn't want to land the stent in the aneurysm, and as it would be free floating, and here we saw that the EL to EL measurement is 3.97 and the lumen measurement is 3.75. So we downsized based on the EL to you can see a quarter size down based on EL, and quarter size up based on the lumen based criteria. We chose a 3 stent and we chose a 333, and we decided to go ahead directly with stenting. We decided to go ahead directly because I won't call it direct stenting, because we pre-dilated with a 2 balloon to initially allow the what do you call, allow the OCT catheter to pass. And now, as I said, we measured the diameters, we measured the length, and looking at the morphology, we can decide to strategize our PCI. As you can see, as it's a mixed plaque, lipid fibrotic plaque, we decided to do a direct stenting. And if there is low calcific burden, you can see we use a compliant balloon. And as we see more and more calcium, we modify our strategy depending upon the amount of calcification to use various calcium ablating technologies. So this, as our plaque looked like a soft plaque with mixed plaque and not much calcium, we decided to go ahead and directly, stent without using any non-compliant balloons.
What
So
is the size of the aneurysm?
it was 4.7, Jyotsna.
Okay. So
Okay.
actually, it doesn't even fulfill the criteria to say as
Yeah.
aneurysm. It is not the one of type. Yeah.
I think
Okay.
I should call it ectasia, right?
Okay.
After our last presentation, if I'm making that mistake, I think it's unpardonable, right?
No,
Okay.
nothing. Just I wanted to know that size.
Yeah. I think I should. So it's so as you can see, we did the post-PCT imaging, and again now it is the max. There is no medial dissection, and we look at the opposition, and we look at the expansion. So these are the three things to optimize the PCI. So basically, we strategized already now to optimize the PCI. You can see that the distally we got very good diameters. The MSA which we are hoping for is more than 4.5. That is the OCT criteria for stent, proper stent management, either more than 4.5 or more than 80% of the reference lumen diameter. And then we saw that we got even at the lesion site 8.2 proximally. You can see that there is malapposition, which is indicated in red. The malapposition was the diameter was the length of the malapposition was 5 millimeters, and it was 0.86. So this was according to the imaging criteria. Anything more than 0.4 position and more than 5 millimeter length should be treated. More than 4 millimeter length should be treated. So we decided to um, again, though we dilated distally with a 3.5, proximally with a 4, again we decided to go ahead and we decided to correct this malapposition by using a 4.58 balloon. So clearly you can see in red here, and on the rendered stent also you can see the malapposition clearly, and this I've shown it here. This is the malapposition.
Is that malapposition is corresponding to the ectatic area?
Yeah, it is, Jyotsna. You can see that we ended the stent. You can see that we ended the stent above the thing. So this is the portion, and this is that ectatic segment where we are seeing the malapposition. We, as you noted, we decided to above this ectatic segment.
Yeah, as I was mentioning the last time, actually you can zoom it and show whether all the three layers are seen or not in the tactic segment, so that then we can decide really proper approximation is required or not, because you covered across the ectatic segment. So if you have then all the three layers, then we can go to the very high pressures to the higher sized balloons without any complications.
So, Jyotsna, you can see the three layers, right? You can see the media intima. So you can see confidently you can go to a 4.5 balloon. Okay. So I used a 0.58 balloon. This is the previous poster dilatations. And then this is also, I used a 4. Then I used a 4.58 again in the aneurysmal segment. So basically, the important thing is I've taken a 333 stent and I've gone from with a 3.54 and a 4.5 balloon. So basically, I made it I made it funnel shaped so that it could fit the artery. So this we know that with the stent parameters, I think all of us should have this stent. A 3 stent can go up to 4.4. I used a Zion stent, and that can go up to 4.4. So confidently, I went up with a 4.5 balloon. So we all should have the expansion stent in the cath lab so that it will help us. So Jyotsna, what I did is I took a 4.58 balloon, as I've told you, and to just correct the malapposition at just that side. So I feel that all of us should have this chart to help us in choosing our balloons. So since it was a 3 stent, I chose a 4.5 balloon. So because the maximum expansion limit is 4.5. So if it is a 3.5 stent, we can go up to 5.6 millimeters. So this is how we optimized the PCI in this patient using a 3 stent and correcting the malapposition with different balloons. And I think this is a thing checklist which we should all have in our cath lab so that we don't we achieve an MSA more than 4.5 and an MSA more than 0.8, more than 80% if we are checking with the average reference. And if we are using long stents, we can cut the stent into half, and the distal half depending upon the distal reference area, and the proximal stent depending upon the proximal reference area. I think this was used in the opinion trial. And dissection we know, and we have to see that there is no plaque protrusion, and malapposition, as I told you, if it is more than 0.4, or if it is extending more than 1 millimeter in length, we have to correct it. And this is what happened in our case. It was more than 0.4 and it was 5 millimeter in length. And most importantly, we have to see that the plaque burden is less than 50% at the stent edges, and there is no lipid pool. So this is one criterion for causing restenosis. So I will now post the post echo so that we did the echocardiogram the next day. So, and Dr. Ganesh will show it, and ma'am will discuss it.
Yeah, one more point I want to add for this stunt under expansion in the Illumin 1 sub-study. Actually, they defined an expansion index in addition to then what is an MLS, what we are calculating this. This is mainly, it's a volumetric algorithm. It calculated as the actual lumen area by the ideal lumen area into 100. If it is then less than 0.8, then it is called as the stent under expansion is present. And the minimal expansion index, that is actually defined as a minimal volume of the expansion index along the entire stented segment. This is an important is mainly to know because this corresponding to the subsequent events of the FFR, decreased FFR values or under expansions. Just to add to the previous methods what we are using it to define the stent under expansion.
Okay, ma'am.
Yeah, please go ahead.
Yeah.
Present the echo.
Okay, you can see the slides. This was taken after 12 hours after the PCA. In the M mode, I could get the same result at the previous only, like 42.2%. And this was, I can compare the things, right? This is pre-PCA, this 4-chamber view, and post-PCA 4-chamber. You can see the contractility also has increased. And the aortic closure time, you can see the synchron also was bettered. This is 2-chamber view. There was definite improvement. The strain has, here it was minus 8.4%, and here it is minus 10.6%. It was 16.5% of EF before, and after it is 31.1. And now it is 3-chamber view. You can see there is so much. It has improved. The synchrony has improved. And this is the bullseye. You can see. And the bullseye, it was the EF, biplane EF, it was, before it was 27.5%, and now after the PCA it is 29.8%, and global longitudinal strain has increased to minus 7.0%, 6.8 to minus 9.1. Okay, you can see the bullseye also. There is an improvement in the apical area mostly.
Yeah, in the bullseye, we can make that the apical segments which were like blue colored and were shown out of phase, they have improved now and they have become light color. So there is increase in the contractility of these segments, even
Yes.
though although there is no significant increase in the global longitudinal strain.
Yeah, it
Pre-PCI
was.
it was -7 and post-PCI it is almost 9. Still it is
Yes.
less than 10%, but it may
Yes.
take some time for the recovery of the global longitudinal strain.
It was
So
only 12 hours. It was only 12 hours
yeah,
actually.
yeah. So
Yeah,
if we
that's
do
correct.
the global longitudinal strain after 4 weeks or like that, we may have some improvement in these cases. So
Yes, ma'am.
immediate improvement we can see in patients who are going primary PCI in cases with acute myocardial infarctions. So in these cases, as we see, immediate recovery of the LV ejection fraction and immediate recovery of the strain rate will also be there. And in patients, like there are studies in CTO cases who have undergone PCI, they have shown improvement in the global longitudinal strain after 9 months of the procedure. So like after 9 months of the procedure, initially the strain was very low and later on it improved. So they were benefited, like to show the benefit of the intervention in CTO cases, they had done the studies and they have shown that there is increase in the global longitudinal strain and increase in the improvement in the LV systolic function.
So we are going to plan after three
And,
months. We are going to plan again. We'll do the strain
Yeah,
imaging for the lady.
yeah.
ma'am, is 3 months an appropriate time
Sorry, ma'am.
to repeat the echo? This strain imaging, should we do it at 3 months?
Yes, ma'am. It is advisable to do it after 3 months so that we can have some clear idea.
Okay, thank you, ma'am.
Thank you,
Dr.
ma'am.
Rupa and Dr. Jyotsna, anything?
Excellent. It's good that more severity of the LV dysfunction is demonstrated by this longitudinal strain, which we don't give much of an importance because we don't know it. That's the reason why we don't do it. Or otherwise, we will be doing routinely. And the most important thing is within 12 hours it is demonstrated. This is another sign of the viability. In the cath lab, not only the FFR, probably the improvement of this contractility. I think we can distinguish from the pull from a surrounding tissue versus real improvement of the tissue by the strain rate. Is that so? So that it
Yes.
is the, whatever we are saying the bullseye improvement is a real improvement of the myocardium, not because of the pulling of the surrounding structure of the myocardium which is functioning.
Yes, madam. The tethering effect and the pull effect, it will be nullified in strain rate imaging, and we can see the actual contractility of the segments if we do assess the regional longitudinal strain of those individual segments.
Rupa?
Yeah, so I think, where in coronary artery disease, it's adding value to what we do, but longitudinal strain has a huge value in oncocardiology. And all our patients who are getting chemotherapy, Herceptin, I think we just cannot do without understanding longitudinal strain in those patients. And we are picking up a lot of LV dysfunction much before the ejection fraction drops when we are following GLSS. So I have a huge use of GLSS in cardio-onco patients. And of course, you have very beautifully shown how it works even in our coronary patients. And using it more, makes us fluent with understanding all the physiology that's happening.
Yes, ma'am. In cardio-oncology and also in patients who are having valvular disease like mitral regurgitation and aortic regurgitation, global longitudinal strain will be useful in assessing the subclinical LV dysfunction even before the ejection fraction drops. So we can send these patients at an earlier stage before they decompensate. So it will be useful.
It's huge in cardio-onco. So for oncology patients, put them onto beta blockers, ACRBs early is so important, and it just changes their outcomes entirely.
We are also doing cardio oncology studies here in Indus Hospital.
Yeah, thank you. Thank you very much, Sujatam. Madam, should we move on to the next case?
Yes, I think it is. I think Dr. Gautami is there.
Ma'am, Dr. Gautami ma'am is already with us. Gautami ma'am, can you hear us?
Yeah, yeah.
Can you share your presentation, ma'am?
Yes, I am. Can you see the presentation?
Yes, ma'am. It has come up. Yes.
So
You are good to go, ma'am.
I am
Ma'am,
presenting.
your voice is very low. Can you come close to the microphone?
Yes. Just a minute. Am I audible now? Hello.
This is better, ma'am. Please go ahead.
Yeah. Go ahead. We can hear you.
Yeah. So I'm today going to present the case of longitudinal stent elongation. So this was a 44-year-old gentleman who was a known diabetic and hypertensive, and he's presented to the OPD with complaints of shortness of breath of 2 months duration. So his ECG was unremarkable. It was normal, almost normal, without any significant STT changes. And 2D echo was also with a good LV function, normal EF. So he was subjected to TMT, and it turned out to be positive. So we took up the case for angiogram, and it showed a single vessel disease in mid LAD. So this was the angiogram. This was the eleocaudal view, and then followed by the areocranial view showing disease in the mid LAD segment. So,
Ma'am, sorry to interrupt you. The files are not moving.
they were not moving.
Yeah, now it's coming up. Earlier, your angiogram slide was not visible. Now it's visible, ma'am.
So this is the eleocaudal view showing lesion in the mid segment of the LAD, and then this is the areocranial view with lesion, and then
No,
the
madam.
plan was.
No, we are not able to see.
Ma'am, your moving images are coming and then it is getting blacked out.
Can you see them now?
No, ma'am, we can only see a black screen.
Oh my God.
Yeah, now it's come, but again it has gone to a black screen. It's just coming like for a second and again going to a black screen.
Gautami sent. Yeah, now it is okay.
Ma'am,
Don't
I
go
think
for presentation more. No,
Can you see it now? See, it's not
yes.
playing in loop. Maybe that is the problem. I don't know.
Ma'am, your slide is not looped out. That's why it's going to black, ma'am.
It is looped actually here. You can see.
Maybe some error coming in. You can go ahead, ma'am. You can just pause it and explain and go ahead.
yeah. First, you show that caudal one. What we are seeing is the cranial.
So I've paused it.
Yeah, you can explain it.
Gautami, ma'am, you are not audible. Ma'am, can you hear us? Ma'am, looks like a technical issue, poor internet or something. We can't hear you. So, Josna ma'am, what do you suggest? Should we go to the next presentation?
Yeah, I think better you take the presentation from her so that you can project from your side. That is better, and we can start with the Saritas, and we can come back to the Gautami later. Is that okay, Madam Rupa?
Rita, it'd be very nice to hear your experience on renal denervation. So over to you, if you're ready.
Yes, ma'am.
Share your screen. Dr. Sarita, you're ready with your...
Yes, I'm just in the process of sharing my screen. Am I audible?
Yes, yes, we can hear you loud and clear.
Um, is my presentation visible?
Yes, yes.
So good evening, ladies and gentlemen. Special thank you to Dr. Jyotsna for inviting me to be here today. And Dr. Rupa, so nice to meet up with you again in another meeting. So today I'm going to be talking about renal denervation therapy. It's a new frontier. And is it really ready for the prime time? A third of our adults suffer from hypertension. Now, way back in 2010, hypertension was the leading cause of death and disability worldwide, and it is associated with an increased risk of coronary heart disease, stroke, heart failure, and peripheral artery disease. And the relative risk reduction for cardiovascular events, they have been shown to be proportional to the magnitude of the blood pressure reduction achieved through treatment. However, in spite of everything that we do, many patients' blood pressure still remains uncontrolled despite the numerous safe and effective pharmacological options which we have. What exactly is the reason? It's you can say it's a combination of things like physician inertia, patient non-compliance, or a resistant hypertension. Previous evidence has suggested that various neurogenic mechanisms, they do contribute significantly to the essential hypertension, and most notably increased activity of the renal sympathetic efferent and efferent nerves found within the wall of the renal arteries. Now, the ablation of the renal sympathetic nerves has henceforth been proposed as a potential treatment for hypertension. Now, there was a widespread enthusiasm for the renal denervation therapy, which was poised as a breakthrough therapy for uncontrolled hypertension. However, that was followed by abrupt disillusionment after the lack of demonstrable efficacy compared with antihypertensive therapy alone. Now, recently there has been again renewed interest in, with cautious perseverance, recent early phase non-randomized sham control trials have now demonstrated significant blood pressure reductions following renal denervation therapy in the hypertension patients. As a pivotal study, the randomized sham control spiral hypertension off-med trial has been statistically powered to evaluate the efficacy of catheter-based renal denervation therapy in the absence of antihypertensive therapy. This was an approach similar with the evaluation of the antihypertensive medications. Recently, we've done a renal denervation therapy in a no-option patient who was having recurrent transient ischemic attacks. He also had a history of a cerebrovascular accident in the past. He was on 8 medications, and he was still maintaining a blood pressure of 180 by 110. So this was only the first case in which we used the Simplicity spiral catheter in central India. So today I'm here to discuss the procedural aspects of renal denervation therapy and how we trudged from here. So this was the spiral hypertension off-med trial, after which there has been so much renewed interest in this therapy. And they assessed the benefit of renal denervation in the absence of antihypertensive medications. They had a sham control trial, and there were no major device-related or procedural-related safety events which occurred up to 3 months. And they looked at the baseline in the office systolic blood pressure and the change in the 24-hour blood pressure. The companion study, the spiral hypertension on-med trial, which tested the safety and efficacy of renal denervation in patients who are taking up to 3 antihypertensive agents, is expected to conclude in about 18 months. The results of both of these will be included in an application to the FDA for approval of the spiral catheter in this population. Currently, there are no approved RDN devices in the United States. So it's a Simplicity Hypertension 3 trial. Now, this was postulated as a failure. Why? Because the main renal artery was denervated. The catheter which they used at that time was bulky, it was unidimensional, and all of these, they have tried to circumvent all of these problems using the spiral catheter. The procedure was changed to reflect the renal anatomy. Now, the renal nerves have a positional bias and radial distance from the arterial lumen. The distal nerves are closer. So the renal nerves generally originate from the aorta and arborize towards the kidney. Now, these nerve fibers, they do not completely converge on the renal artery until beyond the main bifurcation. The accessory arteries, whenever present, have a similar anatomical innervation patterns that mimic the main renal arteries. The procedure was changed to ablate as distally as possible, where the renal nerves congregate closer to the artery. The ablations are only done outside the angiographic shadow of the kidney. The catheter system, energy maximum of 8 watt was given as compared to the cardiac radiofrequency devices, which deliver up to 30 to 35 watts. The temperature is usually maintained between 40 to 75. The generator has a function in which it automatically switches off if the temperature is higher than 75 degrees. And it's now 1 minute per application. So the Simplicity spiral catheter, this is what we used. This is a multi-electrode catheter with a quadrantic vessel contact for simultaneous ablation in up to 4 electrodes. So there are 4 electrodes and they contact different areas of the wall. You can give 60-second simultaneous energy delivery in all of the 4 electrodes. The vessel diameter has to be between 3 to 8 millimeters. You cannot give the energy in a vessel which is less than 3 millimeter. It is a flexible catheter, so it allows entry into all the branches and treatment in all of them. And the catheter that is used for it is a 6 French guiding catheter. Now, the proof of this concept, there is a surgical precedent in the thoracolumbar sympathectomy, which was tried way back in 1931 and 1952. So the concept is to remove the sympathetic chain from the thoracic to the lumbars, and this was found to be effective in reducing the blood pressure. Today, however, it's only performed for hypohidrosis and Raynaud syndrome. So this was the pathophysiology behind it, in which there is increased renin secretion, renin-angiotensin system activation, increased sodium retention, and hypovolemia. Now, our case was a 56-year-old gentleman. He presented to us with recurrent paroxysmal episodes of tingling numbness in the right half of his body, subsiding spontaneously in half to 1 hour's time. He was referred to us for the control of blood pressure. Now, he had come into us almost a year ago, and he had a history of CVA with a frontoparietal lacunar infarct 2 years back. His blood pressure was 180 by 110 on multiple antihypertensives. His biochemical and physical examinations were normal. ECG and echo was suggestive of left ventricular hypertrophy. His ultrasound showed a normal renal Doppler. The metanephrines were normal. He was diagnosed as resistant hypertension with recurrent TIAs. Now, we escalated his current medication therapy with periodical follow-up and checking for the compliance, which was found to be adequate in this patient. Gradually, his number of pills went up to 6 with 2 fixed dose combination. So in total, he was on 8 antihypertensive medication on maximal dosage, and still his BP was 180 by 100. So these were the medications that he were on a 5 mg BD dose of bisoprolol. Prazosin was 5 mg BD, Ditor plus telmisartan 80 mg, cilnidipine 20 BD, isolazine, and his blood pressure would just not get controlled. So this was his renal angiogram. There were no accessory renal arteries, luckily for us. Now, we plan to do all the arteries and branches greater than 3 millimeter. Now, for this catheter, you have to use a stiff wire like a Grand Slam, but the Grand Slam was not negotiating into the branch. So I took a micro catheter and took a run-through wire and then exchanged it over the micro catheter with the Grand Slam. Now, this is the spiral catheter rapid exchange system. It is parked in the inferior branch outside the renal parenchymal shadow. All the 4 electrodes were ablated for 1 minute. Now, when you look at the Simplicity spiral catheter, it has a unique design. It is automatically positions the electrodes to generate 360 degree of ablation. The energy is delivered to the renal arteries through the artery wall. A consistent, repeatable 4-quadrant ablation pattern is there, and it's a 0.014 rapid exchange delivery. And vessel diameter, as I've already said, has to be between 3 to 8 millimeter. The temperature and the impedance feedback is given simultaneously so as to control the energy delivery. If at any time the temperature exceeds or the impedance changes very significantly, the electrode will automatically stop delivering the energy. Subsequently, the middle division of the inferior branch was ablated as it was also greater than 3 millimeters. Then the main inferior branch here, the electrode 1 was kept on a switched off mode. You can deselect any electrode at any time. So if you feel that you've delivered energy at a point and your electrode is overlapping in that area, you can deselect that electrode and give in the other electrodes. Then again, wires move backward. Catheter takes the shape of a spiral, touches the walls of the renal artery. Remember, every time you advance or you pull back this catheter, you have to reinsert the wire. You cannot pull or push this catheter without the support of the wire. The inferior division of the superior pole artery was also ablated. You can see the spiral configuration of the catheter. Every time you pull the wire, it goes back to its spiral shape. Middle division of the superior branch. Then the main body, electrode 1 and 2 was switched off at this point as we had already delivered energy there. Then again, we move to the other side renal arteries. Superior branch of the right renal artery. With the wire, we pushed it a little further as it keeps coming a shade back. Then the stiff wire is removed. Catheter, after the removing, the wire coils back on itself and so shortens on itself. This is similarly done in all the other arteries and the divisions for maximum denervation. And then into the main branch. The final check shoot to exclude any dissection or any adverse complications. There are also other potential uses of renal denervation which are being explored in the cardiovascular system for ventricular arrhythmias, atrial fibrillation, cardiomyopathy, and gestational hypertension, also for pulmonary hypertension, neurological causes such as stroke. So the key takeaways from the European Society of Hypertension position paper on renal denervation. One is that they said the evidence provides biological proof that RDN lowers the blood pressure. Sham subtracted reduction in the ambulatory blood pressure provides the clear message that RDN is effective in lowering blood pressure in hypertensive patients without or with 1 to 3 antihypertensive medication. Second, they said that RDN provides clinically meaningful blood pressure reductions. Although not definitely proven by a prospective outcome trial, we can expect that a 10 millimeter decrease in the office blood pressure achieved in the renal denervation trials, if maintained long-term, would be associated with a reduction in the cardiovascular events by roughly about 25%. The evidence also shows that RDN is safe because no major adverse events occurred in the 3 trials in the short term from 30 days to 6 months post-procedure. The emphasis must be placed on individualized treatment and patient preference given the challenges with the medication adherence. So this is the advancing clinical research with the pivotal trial and the registry. The further data will help us understand what is the ideal RDN patient profile. So we had the earlier 3 trials and then the spiral hypertension off med, and we're waiting the results of the spiral hypertension on med trial. Now, there is also an RDN indication number 2. This is for preferred patients for renal denervation. This is from the Taiwan Society of Cardiology. They had a consensus document on RDN where they said that it is for the resistant hypertension where the blood pressure is uncontrolled under maximally tolerated doses of BP-lowering drugs of greater than 3 classes for greater than 1 month. Again, for patients who have damage, the hypertension-mediated organ damage or established cerebrovascular disease. Third is for the non-adherent patients, a patient preference and adherence explode on a regular basis, and for inscrutable causes such as inconvenience, forgetfulness, etc. Again, also for the intolerant patients who have adverse events of BP-lowering drugs, and then secondary causes that is definitely treated for greater than 3 months, but the blood pressure is still in control, and irreversible causes such as renal parenchymal disease. The take-home message for me, it has been suggested that RDN can be offered to patients as a choice, in particularly in those who are poor compliers or do not like taking drugs. This is fair, and probably someday it can be implemented, but for the time being, it is very premature and potentially dangerous if we say that, because patients who do not like taking drugs for blood pressure control may choose RDN as the preferred option and then forget about other effective therapies with potentially catastrophic results. It is our opinion that RDN could become an option for patients with uncontrollable hypertension if the data from well-controlled studies would show that RDN works as well as drugs, that RDN can reduce or eliminate drug therapy, or that RDN can cure hypertension. Unfortunately, at the present time, we have none of this. And there is no study to date which shows that RDN can replace or even reduce drugs. And there is no data which exists to show that RDN can cure hypertension and potentially eliminate the need for drug therapy. Certainly, we need data using the new methods and techniques and new devices to prove that RDN can cure hypertension in some patients, like borderline ones, reduce the need of antihypertensive medication or the number of medications, We need to also collect data in patients with isolated systolic hypertension and to more carefully define the characteristics of patients who are more likely to respond to RDN. Until then, we would like to continue in our search for this therapy. And meanwhile, we need to encourage patient participation in the ongoing and the future well-designed RDN studies. Ladies and gentlemen, thank you so much. I think I'll
Thank you,
stop
Sarita.
sharing.
Yeah.
My pleasure.
So, it's fascinating how the editorial that I read on this is it literally says therapy in search of disease. So, we have a modality that is good. We know it is a very niche device, and I think in trying to apply it to too many people, it loses its relevance, like a lot of things in cardiology. Well, you've shown a very nice case. A patient is on 8 drugs, and you did a very nice procedure. I must compliment you on that, going into every branch and covering the whole. So I think procedures are niche procedures, and we have to understand them, and we have to be versatile to be able to use them where they are needed. So very well presented and very well covered, Sarita.
Yeah, even I congratulate you
Thank
for
you so
the
much.
tougher case to make a simpler one. And what was the end result? The patient, how much of the drop of the blood pressure was there?
Oh, yes, madam. So at the end result, on the next day, his blood pressure was 140 by 90. So he was still on the same medications that he was, but his opening pressure was 180 by 110. The next day, his blood pressure had dropped down to 140 by 90. So we did not have a medication reduction, but we had a very significant drop of pressure. Also, in renal denervation, they say that the actual results would take, the blood pressure reduces over time. So the actual results would take about 6 weeks for us to see. This case has only been done about a week ago because the first time that this spiral has been available in India was only about 2 weeks ago. And we did this case a week ago. So we are still waiting for the patient to come on follow-up and see what is the further medication therapy that we can reduce the further fall of blood pressure.
So, can you tell us a bit about regeneration of the sympathetic nerves? Because even that happens, and it's I don't know when the patient regenerates, is it just a lesser sympathetic activity finally?
Yes, that is a very valid thought because this is something which they've been discussing in renal denervation is that would we require a repeat procedure? What they've seen is that even when you have a transplanted kidney, there is a reinnervation of the nerves. So these renal nerves have the potential capacity to regrow, to regenerate, and to reinnervate. What they have been finding in these studies is that the potential capacity of these regenerated nerves is not as much as the original nerves. So, but reinnervation is a thing that they're still looking into, and they want to see if they would require a repeat procedure. That is a thought.
So it's mixed, there are a bunch of these patients who need multiple drugs, and the other part is a community base where people will be non-compliant and they want to, give it more as a curative. And I think we haven't understood which is the real patient who would benefit from this. So while we are on resistant hypertension, I don't know about you all, but I find it very useful to, know the fluid excess because a very high dose of vasodilators does cause on a PCM a higher volume. So when you optimize the diuretic and get them dry, that's the time when silnidipine, minipress, so many drugs the patient is on. If you optimize the BCM and the water is okay, then the same drugs become more effective. So sometimes it's just worth coming down on the antihypertensive, upping the diuretic, and then re-adding the vasodilators to get a better response. That's my experience.
Yes, I totally agree. I agree because whenever you look at a hypertensive patient, you have to look at his volume status. You have to look even when we deal with a hypertensive crisis, many times there's so much of pressure natriuresis which occurs, and people look only at the numbers. They don't look at the volume status of the patient. So that also has to be looked at. Absolutely.
On this, when you're on supranormal doses, see in a renal failure, it's fine, but a normal patient on, say, 40 milligrams cilnidipine, 20 milligram trazocin, these are all at this time you're getting the side effects more than the effects, and doubling the doses is not making them more effective. So this titration is extremely important, I think that's something all of us can do till we really get to understand which patient to use the simplicity catheter on.
True.
Yeah, it is an
True.
excellent case. And one more thing is actually recently in the TCTMD website, or also they said that even though we have an accessory renal arteries, we need not to worry. If the size is big enough, it is requires a denervation for them also. So I think it is anatomy nowadays is restrictive anatomy was going off now. Almost the indication is extending to the each and every variety in indicated patient.
I think
Yes.
what Sarita
True
showed
that.
very nice that you need a good support wire to deliver the catheter. And taking the microcatheter down, placing the wire in every branch, it's meticulous technique. It's not just it's just not like you pass a wire and the catheter is there. So yeah, it is a learning curve to it. And when we
I
mass
think
apply
that's why,
to every
Dr.
patient.
Rupa, that is why they said, that when the simplicity, when the third trial failed, so a
Yeah,
lot of people said that there would have been procedural implications because this is a very operator-dependent procedure. A lot of
correct.
patience is required because, in today's world of quick intervention and quick results, it takes a lot
Yeah.
of patience and effort to go into every branch and ablate. So I think
No,
that
no,
is very important whenever
you show
anybody
that.
is doing the procedure.
I show that very beautifully in your case to go both sides, to go into every branch, to switch off two of the electrodes, do the rest of it. It does involve time and patience, and that's I think the patient in whom we'll see the response of.
Yes, I think that's very important that if you are able to ablate into every branch, if you give it the time and the patience, the results come. So at least now we have something for the resistant refractory hypertension patients
Correct.
who don't respond to anything, who are having recurrent events, and we don't know what to do with them. So at least for them, this therapy is now available, and it's a good modality.
Yeah,
So we are
thank you, Sarita. Yeah. Thank you all for the really good discussion, good case presentations. We are beyond the time, and but anyway, I think we enjoyed all the presentations. The Sarita Rao, Sujata, Gautami, Rupa Salvan's comments, everything made us, and of course, Suma left already, made us more knowledgeable and more have an interest in this imaging further.
Ma'am, I have to make a request to you that, cardiogenic shock is something I think all of us ladies, we never leave our patients after intervention. And there's no policy or a document at a national level. I think WINCARS should take a lead on putting the cardiogenic shock, the shock initiative and unloading of ventricle. I mean, I think all of us are very good with ICU care and intervention, and we should take a lead in cardiogenic shock, is my request to you.
Definitely, madam. We will sit together and talk about it. Like we did in a consensus statement, the same thing has to be done as a group team discussion, and then we have to do it. I'm happy that Sarita wanted to present a next time in a calcific lesions, the latest modality. So let us see the
I,
next time
I
our intervention.
I have a case also where I had to do rota and lithotripsy both. So I could also add that case the next time.
Excellent, excellent, excellent. Anyone want to add anything, Sujata?
No, I think we are running out. So
Yeah,
let's.
yeah. Thank you very much. Thank you for the organizers and the presenters, and most important is attendees. So we will be very happy if you give some questions to us also, so that we will also read and come back to you. All of us are of the equal stage and same knowledge, but sometimes strikes to someone and it doesn't strike to the other people. So I wanted the attendees to be the more active and give us the feedbacks.